So why did LA superstar, MLB star Mike Trout need surgery on his meniscus? Or did he? I'm Dr. Tate. I'm a non-surgical orthopedic doc specializing in regenerative medicine. I'm going to dig into that today because it's unfortunate for the guy. I mean, I like the guy. Seems like a good dude. He was leading the majors at the time where they said, hey, we got to shut you down and have surgery. 10 home runs, I think 14 RBIs, bunch of stolen bases, really having a good year. But after the game Monday, he was in so much pain that one article I read said this big tough guy was in tears. His knee hurt so damn bad, hard to sleep. So what do they do? Of course, the next day, MRI that thing. What did they find? A meniscus tear. So I've previously detailed a couple videos here on the channel about meniscus tears. What is a meniscus in the knee? What does it do? What type of tears? So I'm not privy to Mike Trout's medical records, but the fact that he went to surgery tells me he had a pretty significant tear because they were looking at the prospect of him just sitting in a designated hitter role for the year because he was unable to really run the bases with this injury, or attempting to run the bases would potentially make that injury worse. So they're contemplating, hey, do we kind of shelf you in the DH role and just let you hit, and hopefully this thing, if we give you more time, maybe it heals and you can get back to playing positionally as well as running the bases. So medical team weighed the pros, the cons of that, especially at this part in the season, and said, hey, I think surgery is the best route. So we had surgery. So if we look at meniscus tears, again, I'm just going to do a brief recap on this. So the meniscus tear, I just have this destroyed knee, which is great for demonstration purposes. So if we take your thigh bone away and we look inside the knee, this is a meniscus, this white tissue inside here. It's a flexible type of cartilage. And there's different types of tears. I have a video detailing these, but there's radial, longitudinal, horizontal, there's bucket handle, there's parrot beak, there's extrusions, there's root tears. I don't know what version he had. They didn't release that in any of the things I've been reading about this, but I suspect he had some kind of flap tear or potentially a root tear that was making that meniscus unstable, where they said, hey, we have to go in there and surgically fix this thing to give you the best prospect of healing completely after rehab to be able to get back to the team and move this thing along and still capture the sweet spot of the later season and hopefully postseason for them. But when we get into that contemplation phase of what's the best route here, it really comes down to three factors for me. One, the type of tear. So we really have to understand that. Typically, just like him, we're going to get an MRI. Once we know what type of tear, then we really can start to dictate the treatment options, because some of that's attached to time. So for instance, in Trout's case, if they said, hey, let's give this 6 to 8 weeks to see if you can heal, and then it doesn't, okay, and then they go to surgery, and then he's out another 6 to 8 weeks in time of rehabbing that, well, now he's lost 3+ months of the season. So I think from a time standpoint, which is important in professional sports, a lot of time, they're working on a different time clock than the rest of us, mere mortals, where we can take a little bit more time with the injury. So with me working with patients, our approach to it is, hey, we still got to understand the type of tear. If it's a flap tear and it's mechanically locking one's knee, it's going to be really hard to solve with the non-surgical tools that I have and use with my patients. We can rehab that thing. We can use the old RICE method, which is rest, ice, compression, and elevation. We can use the newer methods to try to accelerate healing in that thing. But ultimately, those flap tears or extrusions, where those things, the meniscus is sliding around, it's really tough to treat non-surgically. That's where I'm going to phone a friend, get a surgical colleague involved to do a knee arthroscopy, which means putting a scope inside the knee, putting a tool in there and trying to reattach the meniscus if we can do that, repair it if we can do that, or minimally shave down that meniscus if we can't do either one of those, because we want to preserve that meniscus tissue always. Anything in the knee, I mean, it's preservation, right? We want to save that meniscus at all costs. So kind of to recap, the Mike Trout scenario for why he had surgery, I believe he had some kind of flap tear. They probably weighed options with him taking extended time off, seeing if this thing could heal. I'm sure, they got the best docs looking at this guy and probably had options on the table, including orthobiologics like platelet and stem cell injections that can help accelerate healing. But I think when his team best, brightest minds in sports medicine sat with this guy and said, hey, what's going to get this type of injury fixed definitively to get you back the fastest? He went to surgery. So for the rest of you who are not Major League Baseball all-stars and are dealing with some type of meniscal injury, hopefully this helped you understand what a meniscus is, what does it do, how does it get torn, a little bit about what types of tears. Again, I have more content on the channel here that goes deeper into meniscus, what are they, what do they do, and those type of tears. And then really what do I do as a non-surgical orthopedic doc, because my practice really revolves around the concept of getting people back to what they love doing as fast as possible with the least invasive thing possible. So if that's attractive to you and you like that approach, then like the video. Subscribe to the channel because I talk a lot about those things, everything we can possibly do before surgery. And I'm also going to tell you, when do we definitively need surgery as a first line thing, because many people say that's the last resort, but it should be the first resort for some people to stop at and get that done and just get on with the rehab. A lot of people maybe delay surgery unnecessarily, kind of on a hope and a prayer that it'll get better. My job is to tell you exactly when we can do that without surgery, when surgery is absolutely needed. So if I missed anything, which I probably did, drop it in a comment below and I'm happy to cruise back through there and answer some of those questions. If we can help you in any way, look at your orthopedic problems from a non-surgical perspective, look at the comments, or sorry, the notes below. There's a link in there that will hop you over to a page for my practice where I have able-bodied, smart, happy people waiting to get on the phone with you and discuss what do we do, what have we been doing for over a decade in my practice to help people get back to what they love doing as fast as possible and hopefully without surgery.